record of troubleshooting, problem solving, quick thinking, and utilizing strong analytical, organizational, and communicational skills. So please, Salma, the stage is yours.
Thank you so much, all the team and all the organizers, to give me this chance and to speak up about our experience in leading and handling a quality improvement project in one of the largest university hospital in Saudi Arabia. Uh, I would like to share my presentation. Okay. Is the screen working?
Yes, we see your slides.
Okay.
If you can put it on to presentation,
Yes.
in presentation mode, that we see, yes, excellent. Thank you so
Thank you.
much, Salma.
Thank you. So the first, let me explain the terminology. What's blood culture? Blood culture is one of the lab tests which is injected the blood into the bottle media to determine the presence of microorganism, whether bacteria or fungus, in the blood of our patients. The main purpose of a blood culture is either to diagnose the patient or to prognosis the treatment for our patient, or for the therapy to determine the proper antibiotic use for the patient. Contamination, we mean a growth of the organism in a blood culture bottle were not present in the patient blood stream. So why we are measuring and we are monitoring the blood culture contamination rate? Because we are following the College of American Pathologist accreditation and standard of microbiology standard MIC 22630, which is about the blood culture collection. Sterile technique for drawing and handling a blood culture are defined and made available for individual responsible for specimen collection and practice. So we're starting implemented these standards. As a part of our monitoring, we collected our data and we draw it using a statistical control process. As we see, the average across 6 months was 4.6, which is above the benchmark, which should be less than or equal to 3%. So the team do further analysis based in department, and we found that a number of contaminated sample was highest in adult emergency, followed by surgical ICU. And then we aggregated the data based in department, and we found that almost emergency and ICU has it's almost the same rate, 33% to 36%, and compared to the inpatient, which was 30%, and outpatient was zero, because usually we are not receiving the patient with a bacteremia or fever. So why we are thinking about the blood culture? Because blood culture contamination as a part of quality and patient safety. Because contaminated blood culture will lead to false positive result and will increase the length of stay. One study found that 254 patients with a false positive added 1,372 extra hospital days. It will causes unnecessary treatment. We may give a patient a false antibiotic or a wrong antibiotic. There is a waste of resources and a cost, which is additional patient hospital costs with 1,270,000 per year. Our aim of this quality project was to reduce the blood culture contamination less than 22% after 6 months, but the team were adapted to the vision to achieve a zero contamination. And first, we started formulated our team. I has the honor to be a project leader and working with the other team we formulated a multidisciplinary team from every department, and we did a flow chart to assess the differences between the current process and the ideal process, and we found that there is a missing step in compared to the ideal process. Then the team do a brainstorming and root cause analysis of process. So we found that many causes was defined, and the highest rate was of the causes was related to the process itself in compared to the other causes. Then the team set our measurement and how we measure our improvement process, our outcome, and our process, and the balance of our improvement. Then we set our plan and our action plan. We set our activity and who's responsible, the time frame, and how we measure our output, and our the responsibility to increase the commitment from our team. The first we started as a team to review the guideline for the hospital to interpreting the contaminated sample, and we developed this guideline with our microbiologist at King Khalid University Hospital. Then we set our core team from the highest rate of contaminated sample department from the emergency and ICU. We are involving the service manager to involve the leader and the head nurses, nurse coordinator to help us to educate the nurses, and the IB team also. Then we start reviewing and updated the blood culture collection policy and the procedure. Then from this our policy and the procedure, we come up with 4 products in parallel with the content of the content of the policy. So first we come up with the poster. We post it in every department and every unit to increase the awareness and let our staff to be aware about the process and the impact of wrong collection blood culture contamination. And then we develop a small checklist composed of 5 items to increase the self-dependence and let the staff to be monitor themselves while they are collecting the sample. Then we developing our auditing tool, and then the last one with the help of our IB team. We help the 3 competency assessment, the one for central venous catheter, for pediatric umbilical artery catheter, and the last one for peripheral IV cannulation. Then we start to our testing phase. We choose the emergency department and the ICU department to let the staff, to motivate the staff, and created such kind of competitive culture between them. We started our BDSA in both area. As we see, the pre-intervention stage, the rate was high. Then when we started the first BDSA, which is awareness with the poster, the rate started to be decreased. The second BDSA, we conducted the training for all the staff, and the rate started to be decreased. The third one, we implemented a checklist and IV trolley in emergency, while in ICU we could implement the kit because the area was too quiet and the team has the ability to prepare the kits by themselves. Then the rate started to be decreased more. The 4 BDSA, we found that we need to improve the supervision during weekend and night shift, because all the contaminated sample were reported during weekend and night shift in ER department, while in ICU also we found the same. The 5th BDSA is coming from the defined cause that we need to improve the auditing, and we need to provide assistance, especially in the area of emergency, and we need to remind the group through WhatsApp group about the progress and how's the rate. BDSA number 5 in ICU department, the team was defined. There was one contaminated sample due to they have a difficulty in how to deal with the psychiatric patient. So we did a session and we discussed the team and how we develop a protocol in handling a psychiatric patient. The 6 BDSM, we found that there is a 5 contaminated sample due to a central line collection sample. So we did an education for the sample for the staff, and in ICU we created a physician champion because the sample was collected by a physician, especially the contaminated sample was due to arterial line. And we found that after we implemented all these 6 BDSA cycle, the rate has been decreases. And when we compare before, as we see in here, control chart, the rate before we start to implement it and compared to after we implemented the 6 BDSA, there is a significant improvement in the total rate of blood culture contamination all over the hospital. So we reported our process measurement as a one number of reported back contaminated sample from every department. We found that there is a decrease also in number of reported contaminated. Also, adherence to documentation of a checklist was improved by 100% with the auditing process. For our balance measure, we found that 98% of the staff was satisfied with the improvement, while 2% of the staff was unsatisfied because they feel the workload had been increased. After this improvement, we are celebrating that we are achieving zero contamination in adult emergency in CICU, BICU, NICU, and then CCU during our testing phase. After that, we approved and released our testing policy in all over the university medical city. Then we start to spread our implementations from East Building and then to the medical wards and then surgical ward and then pediatric OB/GYN and then to the other hospital, which is King Abdulaziz University Hospital. The rate started to be decreased and the sustainability had been continued. We learned many lessons and we have many limitations. We learned that involving frontline staff has a critical successful in the project pathway to reduce the resistance from the staff and to accept the change. The key aspect of this project was providing a frequent feedback to the nurse staff and to the key person and feel their value in discussing the causes of contamination and know what is the real cause and let them to be safe to speak up in what's happened with them. And implemented a clinical guideline and promoting evidence-based practice will lead to reduce the hospital cost. The limitation of our project was unavailability of special prepared collection kits. Our conclusion that testing policy change with a simple and rapid cycle PDSA in both department emergency and ICU result in significant reduction in blood culture contamination rate at university medical city. At the final, I love always saying this that teamwork makes the dream work. I believe in the strength of our team and their ability to make the significant change and achieve zero. And we achieved it, this dream work to come up with a zero contamination. Thank you. That's all.
Thank you so much for that wonderful talk. It has been so interesting. And you've been talking a bit about the resistance that you faced. Can you elaborate? Has that now overgone? Now they see those fantastic results? or what is the situation now?
Yeah, we still continue our intervention as implementing the checklist, as provide a frequent feedback, continuous education for our staff, and we're providing an education to every new staff with the IV team, especially in the nursing. The process is still sustained, even it's not a zero, but still we are less than 3%, and we are working within the international benchmark.
Wonderful. Thank you so much. Are there any other questions,
Thank you.
please, to Miss Salma Lafi? Halafi. Okay. Well, thank you once again and enjoy your exceptional work. Absolutely fantastic.
Thank you
Okay,
so
thank
much.
you.
Thank you.